the services panel for 2026. So welcome everybody. Right, Liz is going to do recording. Should we do the apologies before we ask people to introduce themselves? Yeah?
If you want to, yeah.
Yeah. Item 1 is apologies. Liz.
Chair, we've received apologies from Councillor Paxton Hood-Williams, Cheryl Philpott and Yvonne Jardine, and Cabinet Member Louise Gibbard and Officer David House.
Thank you, Liz. Shall we introduce ourselves for those that are online? There's nobody online. Oh, Jeff is online. All right. To show who's here. Shall we start with you, Liz?
Good afternoon, it's Liz Jordan, Scrutiny Officer.
Mike.
And good afternoon, and my name is Councillor Michael Locke, representing Sketty Ward.
I'm Tony Beddoe, an independent member of the scrutiny panels and things like that, and with a background in health and increasingly now these days in social care. So always interesting to see something come up at these meetings, and it always does. Thank you.
Hello everyone, my name's Amanda Williams. I'm a project manager working for Adult Services Transformation Team.
Good afternoon, I'm Lucy Holt and I'm also a project manager working for Adult Services Transformation.
Hello all, I'm Lucy Friday and I'm the Principal Officer for Transformation in Adult Services.
And good afternoon, I'm Amy Hawkins, I'm the Head of Adult Services.
It's Alan Jeffrey, Councillor Uplands Ward.
Sue Jones, convener. Thank you all. Right, we'll go to item 2, disclosures of interest. Are there any disclosures that we need to register? None. Okay, we go to item 3, prohibition of whipped votes and declaration of party whips. Are there any comments? We go to minutes of the previous meeting. On the 8th of December. So we go through the minutes, page 1, page 2 and page 3. I have voted everything. Thank you, Mike. And we accept those as a correct record. Item 5 is letters. You've seen the letter. Just for your comment, if you have any comments on the letter. That's it. Item 6 is public question time. Liz, are there any?
No questions, Chair.
Thank you. Item 7 is the performance monitoring. Who's going to take a lead? Amy, are you going to introduce it?
Yeah, I'm not going to take a lead actually, so my
No.
colleague Lucy is, but I will introduce it. So this is our monthly performance report. We bring them here every few months to scrutiny. Just to mention, this is an end of November report, so it feels like a lifetime ago in some respects now, because we had significant winter pressures in November, taking us into December and early January. We're starting to see a real corner turned in terms of those pressures, but we've still got areas of high demand now. But this information you're going to be looking at, just to put it in the context, it is a couple of months out of date, but we will bring another one to you, which covers this period as well. So if I hand over to Lucy, thank you.
Thank you everyone. Okay, thank you. Thanks, Chair. Okay, so as Amy said, we're reviewing data as of November 2025. On the front page of the report, you'll see headlines aligned against each of our priority areas of prevention, promoting independence and prioritising resource. I won't go through all of those word for word, but I'll focus in on those headline areas. So looking at prevention and starting with our front door to adult services, the common access point. During November, we did see a significant decline in demand by approximately 22%. So we had 608 new referrals received into the common access point compared to 755 for the preceding 2 months. So not to be concerned though, I mean, this is not that lack of demand into the front door would be a concern, but it's not dissimilar to the same period last year. And to mention that in December, we saw a return to standard levels, really more consistent demand. But what is worth noting, the reason why I bring it to your attention, is that the decline has obviously then impacted on resulting demand into other teams. So when you look at other performance reporting, it might look a little bit out of kilter with what we usually see and what we normally bring here. So just keep that in mind, that we did have a lower number of referrals into the front door during November. Despite that, of the referrals that we received into the front door, of course, we continued to provide the continued level of early help activity that we'd expect and that we've come to see over recent months. So in November, the proportion of contacts supported with advice and information only increased to 51%. So again, that's just an ongoing improvement that we're seeing month on month. In November 2024, that was at 44%. So that's continuing to work well. And of course, that's one of our key pillars of our prevention model. Similarly, referrals into the early help community wellbeing team have remained consistent. Again, the demand generally dropped, but overall caseload continued to maintain at 60+ individuals month to month, and the number supported entirely by the short-term intervention with no ongoing referral to social care remained high. So 69% of all those cases that closed during November from the wellbeing officers were closed there and then. There are no ongoing care needs, no referrals onto social work, which again is a fantastic outcome and aligns with our early help model for adult services. Also happy to say that we saw an improvement to carers assessments completed in November. So we had an 18% increase on the same time last year. As mentioned in the report, in the narrative, we've seen improvements across both identifying carers at the point of contact and the total number of carer-specific active care and support plans in place. Just to give you an idea, I didn't include this figure in the narrative for November, but as of December, we had 635 active carer support plans in place across adult services, but we're still below the level that we need to be. So we know that's an area that we really want to focus in on. So there is ongoing work with partners. I mean, it is worth mentioning that with our carers assessment stats, we don't refer, those are only assessments completed by adult services. So we don't include any assessments that are completed on our behalf through our commission services like the Carer Centre, which would also increase that number. But overall, we know that we're still a little bit below where we'd want to be. So we are doing a lot of work within teams to actually improve that position, try and get a better uptake of people actually taking forward the assessments. Yeah. And I think that it's about that point of contact into the front door. If you're ringing on behalf of another person, you're the carer, your concern is going to be on the care and support of that person that you're caring for. It's unlikely to be about, you're not at that time perhaps thinking about yourself. And that's the bit that we really want to turn, and the bit that we want to understand better, so that we can really see how we can engage with carers in a more proactive way. But already inroads have been made to that, and yeah, there's been a real active promotion of carers champions across our social work teams, and really embedding it across all points of contact into adult services, see if we can improve that position. So moving on to our promotion of independence area. So in this bit, we're really concentrating on our reablement services, and we're looking at referrals that come through to reablement and our reablement caseload, both from community and also our hospital pathways as well. So our residential reablement admissions were consistently high during November. For Bonamine House, our occupancy in month was at 98%, which is fantastic. And we have spoken about Bonamine House here on a number of occasions. The outcomes, as you would imagine, continue to be good for individuals that we support in residential reablement, with the vast majority remaining or able to return home rather independent, which is the best outcome we could hope for. So really our focus now as well is surrounding the support and processes surrounding Bonamine. So the activity within Bonamine House and residential reablement in T Westfield as well, we know is really good. We've got good practice and excellent outcomes for individuals that we support. What we're looking at now, and work that my colleague Lucy Holt is actually doing, is looking at the surrounding support network of those same services. So what can we do to improve a more timely next step for people who are coming through residential reablement? And that often involves other practitioners and professionals like social workers, our domiciliary care brokerage teams, and just and early help as well. So we're thinking about how we can better improve those areas, which again we'll just see further improvement in what is already a very successful model of delivery. So we are making inroads in that area. Home care reablement, we have seen a slightly lower caseload than we would expect. So that's been a trend that we've seen since last time we reported here, I think, which would have been October, I believe. October, no, it would have been earlier than that. Sorry. We have seen a bit of a downward trend in terms of our caseload. There are a number of factors that have influenced this, and it is something that we're looking at very closely to understand how we can turn the tide a little bit. But some of the factors that are influencing the caseload in home care reablement have been, you know, our organisation of the team. There have been some changes in the team in the month of November. We've reorganised to better meet the needs of our communities, move people into different areas and so on, so that we're really trying to make the most of it. We've also seen, as you'd expect, and this has continued for some months, we're obviously taking an awful lot of referrals via our hospital discharge pathways. That has also correlated with a longer average length of stay and higher acuity of need. That is being taken into consideration as well. It's not the whole story, but all of these things put together can make a difference. And again, we know that there are improvements, as I said, with Bonamine. There are improvements that can be made with the process from discharge from reablement on to the next step of that person's care journey. So where ongoing care is needed, we could do more to make that more timely. Yeah. So, however, a real positive that we saw and has continued into December's data as well is that the outcomes for the individuals being supported through home care reablement have significantly improved. We are seeing a far higher rate of people leaving reablement independent. So our average for November was 53%, and our previous 6-month average was at 34%. So, you know, swings and roundabouts with this. We are seeing a longer length of stay, which does impact on capacity, but the outcomes are improving for individuals. So we're taking that all into consideration. And then lastly, reviewing our activity against prioritising resources. In this area, we're really looking at the whole system, really. It does cross over into some of the points that I've already mentioned, but really it's about making sure our systems are working, are optimised, and making sure we're making the best use of our available resource so that we can offer the right support at the right time. So as already mentioned, our internal home care service, we need to improve our capacity, and we really want to make sure that we're maximising on that at all times. To this end, though, we have seen an improvement in some areas, our bridging caseload and length of stay on bridging. So that's people that are still that have finished their reablement intervention, but home care still provide their support whilst we're waiting for an externally commissioned dom care provider to come on board. So there has been a reduction in that length of time that takes, which is great. But we know we can make that even better, and we can improve even further. In our externally commissioned care, we saw an increase across both client numbers and the hours commissioned. This really correlates with what I've previously mentioned about our home care capacity in part. So if we have a below target number of new starters in reablement, we will see an increase in directed domiciliary care provision with no reablement beforehand or right sizing activity. Another big factor that has also influenced on our increased numbers is that we've seen a great improvement to the number of initial assessments being completed, and our waiting lists have significantly reduced. This is really positive. There is a knock-on effect to that. So obviously people are accessing our services quicker, which is brilliant. Of course, we'll see then an increase. So, but again, for the person, that is the way it should be. So the decrease in wait times for assessments is definitely a positive. So just to give you an idea on those, for our new contacts or initial assessments for the reporting period that we're reviewing here, it stood at 79 people at the end of November. That's since reduced. So as of today, I know that we were just in a meeting earlier today, and that number is down to around 55 people awaiting, and that continues to improve month on month, which is a really great news. And then last but not least, our safeguarding referrals. So you'll see that we've maintained at a high level However, to offer reassurance to panel, the team continue to manage this demand robustly. And of course, we have our triaging in place at point of referral. And although the demand has gone up, our prioritisation and our completion of referrals is still within the timescales that we would hope for. So those are the headlines, Chair.
Thank you, Lucy. Are there any questions for Lucy?
Thank you, Shane. No questions as such, really. But a lot of statistical information there and pictorially represented, very colourful, pretty to look at. And I just taking the first one as an example, page 13, because I've been involved in maths for a greater part of my life. I was just looking at the representation. I take it that the top part, or the common access point, where it says information for advice and early help, is displayed vertically then on the last column, November. I'm on page 13, yeah. Yeah. Not that it's rocket science. I was just looking at, I was trying to picture the two of them together. As an example, if you take the last one, the referrals, 253, that was in blue, but in the column below is represented in red. And I thought it might be, and just a suggestion, it might be appropriate if the color coding matched. I mean, it doesn't take much to work out, but that was it. But I didn't fully grasp until you actually gave your presentation a moment ago about the 355 referrals. I assume that some of those would have been referred for integrated therapies, some would have been provided, right? So because the 355 was not represented in the column, so it took me a little while just to grasp that. It's just a thought, but otherwise, thanks for the presentation. You do an awful lot of work and should be well commended. Diolch yn fawr. Thank you.
Thank you, Alan. Councillor Jeff Jones.
Yeah, thanks for that. A lot of information, as Alan's actually said. I know you mentioned at the start, actually, about the 20% drop in demand, shall we say, with the common access point, which is, I think, has been a great success. And I know you're refining it and so on. You mentioned every November this happens. What's the driver behind this? There must be some sort of reason at the end of the day why people really haven't got a demand for social services in November, December. Can you perhaps expand on that?
Thank you for the question. Yeah, it is a bit of a puzzle. I mean, I would say that actually the margins that we're talking about, though, total, are quite small, I suppose. And although it's consistent with November last year, but then December last year we saw 575 reported, and I know that we're a higher level than that for December just gone. So it's there's no real rhyme or reason to it other than overall it's still a high level of demand, I suppose is what I would say. Relatively speaking, it is a drop to what we've been used to. It's been bobbing around well over 700 for the full year, so it is below that level. But in terms of the integrated therapy proportion and our proportion that are coming through for social care, they remain fairly consistent. But yeah, I couldn't give you a definitive answer as to why. If it were to continue, that would be something we'd definitely investigate further. But no, and I do know that actually saying that, we've also heard similar feedback from other areas of the system as well during November. So I think this is must be a common drop in demand that we're seeing, but yeah, still consistently high when you look at the totals across the year.
Yeah, it does seem a bit strange that people, shall we say, don't require social services as much really over the Christmas period. I'd have thought they'd require, the demand would go up. But anyway, okay, that's thanks for that. Another part you actually mentioned there as well is with regards to why carers are refusing the carers assessment. Well, what's the reason for that?
Again, I think we do have a number. We are seeing an improvement in the take up of people who will actually have an assessment. But I think as I offered during the presentation, it's the point at which we actually offer the assessment that's really vital here, isn't it? Because I think that at the point of contact, priorities for the carer might not be based on their own care and support needs if they're contacting us. So although the offer is being made and in some cases it is being taken up, we know we can improve further. But that's not to say that it's not, we are seeing an improvement on that overall again this year. But there is further improvement. But I think it's about the timeliness of that offer. We need to repeatedly offer, don't we? We need to have, which is what we're broaching with support from the carer centre, so that we can improve that number. But I think it's really about the timing of it, and where, as a carer, your focus might be at the point of where we make that initial assessment offer. So really broadening out those opportunities is where our focus is going to be.
Okay. Yeah, a couple of pages, page 17 and page 18. It's only really clarification. You actually, mentioned, some of the cases transferred or closed. And again, on page 18, referrals to, sorry, I can't read my own writing here, pass on track if they are successful. Who are they actually passed on to? I know you've got a pie chart actually on page 18 with very small there, CAP assessment, community, South Wales, East and West, review, and sorry, I can't read there, another. So what exactly they actually passed on to other sections, and do they actually come back again if they are, should we say, unsuccessful, whoever you actually pass it to? What exactly do you mean with regards to referrals, or referrals closed?
Okay, so that particular page refers to our Home First social work team.
Mm.
All of our social work teams and our front door, though, will have opportunity to transfer or close a case once their intervention or their step in the pathway is completed. So we always move forward. So forward momentum is our model of delivery. We don't tend to pass back, or we certainly do everything in our power to avoid that. So just to offer assurance, if a case is transferred, it's because that particular team's intervention has completed. So in this case, on page 17 and 18, the Home First social work team have a very primary focus, which is in that hospital intervention. So at the point of someone being admitted into hospital, where appropriate, the Home First social work team become involved. Then once they have completed their intervention, that person has returned home, and their intervention has completed and the longer term care needs are established. What would then happen is a referral through to a community team. Now the pie chart, I'm hoping, reflects this. Yep. So the vast majority you'll see on that pie chart, the big purple one, which is just over 91%, is our review and reassessment team. That's essentially, for all of our adult social care referrals, that's essentially our caseload team. They're the people that hold all cases, and then complete annual reviews and any reassessment queries. So if someone has been in hospital, for example, if I've been in hospital, I've been referred through the adult social care hospital social work team. Their intervention with me had completed. I'd return home, perhaps with a domiciliary care package or something similar. Then I would be informed when their intervention had ended and who my ongoing caseworker was, if you like, for want of a better phrase. So who the team would be that I would then contact if I needed to contact adult services. And in this case, that would be the review and reassessment team. And likewise, that team in turn would contact me annually to complete my review. But yeah, we always try and keep a forward momentum with all of our caseloads. So from the common access point, you'll see very strong forward momentum where social care intervention is needed, and then from assessment onwards. But most roads do lead to our review and reassessment team. They're the ones who hold our caseloads in community. I hope that clarifies it. I know it's quite a complex system to describe, so I'm not sure I did that very well, but that's essentially the model.
Oh, okay, very good. Thank you.
Thank you, Jeff. Councillor Mark Tribe, you've got a question?
Thank you, Chair. Just looking at the internal residential facilities, Rose Cross, St John's, the Hollies and T1 Allied are mentioned. The two new developments currently under construction in Orchard Street and St Helens Road, would they be included in this report? Were there any future reports? And if so, would there be a bit of extra pressure on this current staffing levels? Thank you.
I think you might be referring to accommodation that's linked with our colleagues in housing. Is that right? That would be the St Helens one, I think, as opposed
right,
to
yes,
care.
yes,
So it's particularly housing related support accommodation there, whereas the internal residential care homes we're talking about is 24-hour residential care needs for predominantly older adults, but it can be those with additional complex needs. Whereas I think the developments that our housing colleagues are doing is around temporary accommodation for people whilst their longer term residential accommodation is supported. So we will work together as services, so where there are needs of individuals who are coming to housing provision that need the support of adult services, we link in and yeah, we support in that way. But no, they're quite different developments. So these are just our internal residential services. I thought you were going to query actually about the external providers, because there are 36 residential and nursing homes in Swansea run by the private and independent sector as well. So we don't always include every single.
Just wondering whether they were part of the structure at the moment. Thank you.
Thank you, Mark. Are there any other questions? Well, Lucy, thank you very much for the presentation.
Sue, sorry.
All right.
I got my hand up. Sorry.
I didn't see you.
One more I wanted to let it.
Okay.
Yeah, it was only really on page 42, external provision. It says actual versus undelivered. I think undelivered was 20%. What exactly does that mean? That they didn't come up with the goods to provide the 20%? And what happened to the 20% afterwards? Who actually met that?
Okay, thank you. Yeah, so that's our plan versus actual for our externally commissioned domiciliary care. So there will always be, so planned is what we commission, and then actual is what they deliver. Sorry, just to make that absolutely clear. So yes, you're absolutely right. For October figures, so October 2025, we saw 81% of the hours we commissioned delivered, and then 19% not. There's a huge range of reasons for that. And that's actually a much, as you'll see from the graph, an improved position. Obviously, we will make that red as small as possible. But there are a lot of factors that we have no control over. So there will be an element of occasions where providers call out to deliver domiciliary care and the person does not answer the door or is not home, or it's been cancelled but they've not been given any prior notice. So that's quite a bit of it. And there's also, I believe as well, I might look to my colleague Amanda here because you're actually involved in the recommissioning of domiciliary care project. Our target was to get to an 80-20 split. That was our perfect, using our commission providers as a benchmark. That would be the minimum that we would look for. And there's been an awful lot of work done with our commissioning colleagues to really bring it to the level that we have. So it is an improved position, and it's not under delivery, if you like. It shouldn't be seen as necessarily a negative, rather a nature of the beast in terms of this type of scale of commissioning and the delivery of hours and the number of variables that can happen when you're going to people's homes to deliver care. Would that be a fair summary, Amanda? Sorry to put you on the spot.
Yeah, that's right. Yeah, it's a minimum of 80%. It's got a lot better, and we're looking to further improve. But like Lucy said, there's a lot of factors why we don't ever deliver always the planned, and it can be the person's in hospital as an example, and we would honour that call if it depended on the notice given. Yes.
Thank you.
Okay. Can I just ask you a question? Delays in the package of care, is that down to the brokerage situation?
So it can be. So we know that there is there are improvements that can be made. So what we do know and what we've really improved on is our framework of delivery of providers. So we've got more providers providing domiciliary care than we've ever had before, which is fantastic. So there isn't a lack of provision or a lack of availability. Our brokerage processes have been improved. Lucy Holt has done an awful lot of work with that team to improve our processes. So it is now, we're refining it for our internal processes. So the providers are there, able to pick up work. The steps from the team that they're being passed to, so the stage steps involve not just brokerage but also social work assessment as well, and other professionals being involved. There might be a therapy assessment, there might be the provision of equipment, there might be a number of different factors that come into it. Brokerage is one of those, and we know we can improve our processes there even further, but there have been inroads made there. And then the next bit that we're really going to be looking at as well is about a more kind of targeted approach to our social work assessment step at that stage, so we can improve upon those figures even further. But the delays are, you're right, it's normally brokerage processes. Help.
Thank you, Lucy. Safeguarding referrals, they've gone up quite a lot. Is that our system sustainable to deal with that?
Do you know, that's a really good question, and that came up at our internal performance meeting yesterday as well, because we look at obviously we were looking at the December report, and we've seen a continued trend into December from the last 3 months. So at the moment, it doesn't, if it keeps continuing this way, no, it doesn't feel like we've you know, got enough resource and enough sufficiency in that space to be able to address all these. But we are just tracking it at the moment because it might just be a spike from the last sort of 3 to 4 months. The number of consultations we're doing with people still remains high, so we know that so although it was a dip in November, we will have to look at it, but generally the trend has remained high. So we know a lot of people are coming for us for that advice and that early guidance rather than putting in appropriate adult risk reports and to provide that early intervention. But yeah, it's just a higher number of adult risk forms, so we need to really look at why this has, and as you'll see, a number of them are taking longer to complete as well, so they are getting quite complex as well. So yeah, we are yes, absolutely keeping an eye on this, and we need to look at, and if we need to move some resources around to get some more capacity in the team, we will. But at the moment, we're just seeing if this is a spike or an ongoing trend. And we're comparing, sorry, just say we're comparing what it's looking like across Wales as well. Doesn't mean we do anything necessarily differently, but we're just seeing if we're an outlier or if this is something.
Is the trend across Wales?
I can't give you the answer yet, but that's what we're looking at.
Thank you, Amy. Are there any other questions then? Thank you for the presentation. Okay, we go on to item 8 now, the Transformation Improvement Programme update.
Going to do a similar approach again?
Yes,
please. Just introduce this. So as a key part of our target operating model, so as we talk about a target operating model, which is our 4-year plan, we're in year 1 of 4, about how adult services delivers all our activities in a sustainable way within the resources we have and with the demand we know is out there, as we just talked about in our performance report. We have underpinning this is a transformation activity. So it's a number of programs that help deliver our target operating model, so help get us where we need to be. So Lucy and the team have done this report around where we are in terms of those different programs. So yeah, some good things to report on. I'll pass over.
Thank you, Chair. Thank you, Amy. Me again. You're going to be sick of my voice. Sorry, apologies in advance. Okay, so as Amy described, within the report, we are summarising on the purpose, the priorities and the progress of the Adult Services Transformation and Improvement Programme for 25-26. So I'll talk through each of the 3 priority areas just as the report's been laid out, and just as a reminder, we've just talked about in the performance report, prevention, promoting independence and prioritising resources. And we've also pulled out some key sort of performance measures as well that really demonstrate the impact of the change and improvement work that's been happening across the service. First of all, a little bit of background. I won't repeat what Amy just said. I mean, you understand very well the target operating model for adult services, obviously. But, you know, our transformation programme at the very root of everything we do, and any project in any step, is about that vision for adult services. We remain that you know, we keep that at our core. So working alongside you to live well and safely in our community. And, you know, essentially everything we do all leads back to the same principles and outcomes, you know, to support people to live well and independently within their communities for longer, and to make sure that carers feel supported, and to enable staff as well to deliver high quality person-centred support. Of course, though, this is taking place against the backdrop of some very major challenges, as you're all very aware. So we are seeing an increase in demand, not necessarily in November, but we are seeing an overall increase in demand for adult social care, as needs across the population continue to rise. And of course, there is significant financial pressure. So we are really trying to deliver our model very differently to historic provision of adult services, and to make the very best use of our resources. So the transformation programme is really about how we respond to those challenges. That's essentially our work as a team, year on year, and our programme is really those key areas of improvement. So in the report, you'll see that I offer some narrative around some of the work and activity that has happened in years since April 25, and also the headline impact, I suppose, if you like. So starting off with prevention. So as you know, that's the foundation of our approach in adult services, and our expectation, and why it aligns with our target operating model, is that by embedding early help and community-based support, we'll reduce unnecessary escalation into managed care. And we ensure that people access the least intrusive support as possible. So as a quick run through of our key developments in year, we've established a new adult services early help team, so bringing together new and existing roles into a coordinated service. So I know that Sue Parage, the principal officer for early help, came to a recent scrutiny panel and described that in a bit more detail. But, you know, the appointment of Sue herself, and we've also had an early help strategic lead for the third sector as well, which we've commissioned through our partners with in SCVS, and also a commissioning lead for early help. As well as an increased number of early help roles, which we're using across all of adult services and all pathways, as well as, like I say, bringing together all of those existing community roles and roles together. So it's a more coordinated approach under the leadership of Sue Parage as our principal officer. And those developments really mean that people contacting adult services now have an earlier, and we hope more holistic, sort of support options available at not only the front door, but also prior to contacting us at all, and then ongoing through their engagement with us in adult services. So some key sort of headlines attached to prevention. So from April to November 2025, we had 3,222 social care referrals to the Common Access Point. So that's social care referrals only. That doesn't include any referrals through to our integrated therapy teams, for example. And of those 3,222, we had 47%, so that's just over 1,500, were resolved through information, advice and assistance alone. I know we talk about this in the performance data. I know we talk about it a lot, but it really is quite incredible, and I think it bears repeating. Those are our access and information assistants. They're picking up the phone and speaking to you for the first time, and they're able to offer such robust advice and guidance that people are confident and happy to say, okay, thank you, yeah, that'll do for, you know, that's all I need for now. And there's an open door policy. We know if they need to return to us with any further questions. So, you know, and that's really remarkable. What we're doing as well is trying to expand our performance information to better understand if people do return to us and ask more questions, so we can look at doing something different again. And again, that kind of is echoed in our early help multidisciplinary team. So our wellbeing team, I've talked about it here before, I know, and just talked about it in the performance report. But overall, so this is a really small team. It was 2 part-timers up until fairly recently, where it's expanded to a massive team of 4. And our early help multidisciplinary team, they're based within the Common Access Point. They're part of our wider early help team. And they are commissioned through SCVS again. And in the period that we're referring to, April to November, they've supported 154 individuals through wellbeing plans and short-term interventions. And as I mentioned in the performance report, the percentage then that required no onward referral to social work was at 72% for the year, which is really quite impressive. And likewise, going back to our carer support plans, we have seen a significant increase, actually 74% increase for this period compared to the same period year before. So we've seen 613 active care and support plans for our carer population, and for the year before, for the same period, that was at 352. So again, a significant increase, as already mentioned. Still more to do, but a very improved position. So we're showing a clearer and stronger prevention pathway. People are getting the right help earlier, more carers are supported, and fewer individuals are entering long-term managed care unnecessarily. So essentially that brings us right back to our target operating model. Moving on to promoting independence. So that's the next stage of our pathway. So it's enabling people to recover and live safely at home for longer. So this area focuses heavily on reablement and transforming the way we work across both hospital and community as well. So as mentioned, our internal reablement service has hit some issues with their capacity of late, but having said that, for the whole period that we're looking at, they've continued to expand their capacity made some significant inroads. We have a transformation program called Rebalancing Domiciliary Care. That's been active for a number of years for 2 years on our transformation program. And really that's about how we better organise our internal home care provision to offer the right support at the right time. It's a fantastic service. We know that we have the right skills in-house to provide excellent top-notch reablement service, and we have expanded the capacity significantly within that team using existing resource mind. This isn't about increasing the numbers of staff necessarily, it's about using them differently and making sure that we're more efficient in our use of our resources. So we've reorganised our capacity, we've refreshed our reablement training for staff as well, and we've strengthened processes across social work. Our integrated working with therapies is massively improved, and as previously mentioned, our brokerage processes and just engagement with our brokerage colleagues has improved as well. Likewise, we probably won't talk about it again, but residential reablement, Bonamine House and T Westfield has really been optimised, and with a great deal of work with our health board partners as well. Our step down to those services is vitally important. So step down from hospital, it's a fantastic option to be considered by our integrated discharge hub in hospital sites. So closer working, which again my colleague Lucy is working a lot with health board partners to really bring together that integrated MDT approach so that we're working smarter and more efficiently across all of our partners. And on that note, actually, in this year as well, under the transformation programme, we did have the launch of the Pathway of Care Delay grant from Welsh Government as well, which we've taken full advantage of in adult services, as you would expect. So again, this is the programme that Lucy is managing in the transformation team. And really, it's about us establishing a new Swansea specific delivery MDT, or a delivery multidisciplinary team. So bringing together early help, reablement, therapies, social work and brokerage to provide that seamless post-discharge from hospital wraparound offer for people. And the grant has really given us the opportunity to run with that, which has been fantastic. And then on the other side as well, as a massive part of our promoting independence, we've also progressed with our digital and assistive technology offer. So I think it's been a while since I've been here to talk about that necessarily, but we launched the Smart Suite earlier on in this year, quite early on in the financial year, to trial independent living technology. So that's like a demo suite, and it's been a big success. We've had a lot of attendance from our internal teams. We've had around 200 people come through the demo suite already, but they are all internal staff. But that is training, and that's, they're learning about it, and that's come from different teams. So we've had people from the Common Access Point, people from home care, people from therapies, all taking a great deal from just engaging with what the Smart Suite has to offer and demonstrate, and that informs their practice when they're working with people and what they can describe as being the offer. And this year as well, just lastly on assistive tech, we've also launched a self-assessment tool, which is called Ask Sarah, which anyone can use, professionals or you and I. And it's a great, really easy to use online tool that you can go onto. We've made it Swansea specific, we've branded it, and we've also included a load of information about our early help offers as well while we're at it. But it just gives people a bit of a help in terms of understanding what they could access themselves easily and where from, to help them live at home independently and safely for longer. So I would encourage anyone to have a look at that. Oh, awesome. I'll turn mine.
Is that advertised out in the communities? Because that's really exciting to realise that that's, yeah.
Yeah, it is. I mean, it is really exciting. It's taken us a long time to get to the point where we've actually been able to launch it. So yes, it will. We've focused our promotion internally, but externally it's being promoted as well. It's all, as I said, it's all Swansea branded. It's web based. But when people go on to Swansea Council, I know that our communications colleagues were looking to have a link as far up as we could on the web page, so that people, if they hit Swansea Council homepage, will be able to find it easily. Because we really hope that will be a helpful tool to a lot of people and a lot of carers as well.
And can I ask you about the Smart Suite?
Yes. Yeah. Yep. So that's based up in Sure Equip in Morriston.
Right.
So our community equipment store and our assistive tech service are based up there. And we have an assessment centre up in that site, which was developed some years ago actually, and it's really successful for our internal training. So a lot of our integrated therapy colleagues use that for ongoing training, as our home care team do as well. So our recent reablement training for the home care team took place up there. And so we have a number of rooms up there. We have a fully operational working kitchen up there as well, with up and down riser counters and different kitchen aids for people to use at home. And then we built this extra room. We appropriated a room and turned it into our demo suite, which is essentially like set up like a house. So we have like a little living room area, and then we have a bedroom area, and we set up a mixture of telecare devices, as in devices that we assess for, and you have to come through us for assessment for therapies, like bed sensors or door sensors and things like that. But then also we also have information for people who might want that as a bit of a preventative step and would actually just like to access it themselves. And a lot of kit and technology, which is focused more on things that any of us can get, like Alexas, and then the real broad range of what those same devices can do to support independent living, voice activated lights, blinds, auto shopping from your fridge, and sensors when your milk's gone, it automatically orders it through Amazon for delivery, and all of this. So I know it's a different world. So that's been a good success. I think a lot of people, until you get up there and see it, I think it's quite difficult to imagine, but it's just a good way of showing it in situ, you know, because when you describe these things, it sounds a bit like, oh, okay, I don't really know how that would apply to me in my day-to-day life. But I think if you're down there and you can see it, then maybe that helps a bit. It is only, so at the moment we've got it up there. We are investigating whether or not we could we're working with colleagues in Bonawine House to see whether we could also investigate using it as part of the having an extra demo area down there as well in Bonawine House. Again, it's just about having more places in the community that people can access and actually review some of this tech. Sorry, now after I've gone on about assistive tech for a bit. Okay, so our performance headlines for promoting independence. So we had 492 new reablement starters from April to November last year, and that's a 21% increase on the previous year. And 53% of people leaving reablement were fully independent. And that's up from 46% the year before. And I think because we're so used to seeing these figures at quite a high level, we might get a little bit complacent about how good that is, but that's incredibly high. That is really showing the benefit of the services we have in place, or the excellent services we have in place. And our average time in the reablement service as well. So the average length of stay in reablement reduced down from 36 days to 26 days, which is a positive. That's still a long period of time to have reablement support. And of course, that's an average, so it'll be a lot more than that for some people and a lot less than that for some people. But overall, it means that the reason why it's important to us and our delivery is that it means that at the right time people are able to access our services, and the right time people are able to move on to the next stage of their care. As I said earlier, Bonamine House has maintained its occupancy with an average at 98% recorded in November. And our residential reopenment outcomes, they've unbelievably, because I don't know that they could have got any higher, but they have improved again. So we reported 78% for the same period last year, and this year we came up to 93%, where needs were either mitigated or reduced, which again shows the overall impact and a real reablement first culture that's coming through our services, which again is a key part of our target operating model. And then lastly, sorry, Chair, I know I feel like I've been talking forever, are prioritising resources. So in this area, we're really talking about maximising our capacity, strengthening pathways, or improving our systems really and our models of delivery to make sure we're offering the right support at the right time for people. So we're progressing with our recommissioning of domiciliary care. So this is the work that Amanda Williams, my colleague, is leading on with commissioning colleagues, which has included a full review of pilot models. We're analysing other local authority approaches to commissioning domiciliary care, and also there's, as you would hope and expect, a great deal of engagement with providers, service users and unpaid carers as well to inform our future commissioning model in that space. And that's the target is for that to go out to tender late in 2026. We're also advancing the new day services model, so we're shifting towards more community-based support whilst retaining our building-based provision where needed. And then on the other end of the spectrum, completely different but no less vital to our delivery of our prioritising resources, we're also scaling up our digital innovation. So on top of the digital options that I've just described in the space of assistive technology, in terms of our practitioners on the ground and our people actually, delivering services in our teams, we're piloting the use of, as we all know, we've all got Copilot, so that we're looking at how that can be best used across social services. But we've had a really successful pilot of another AI intervention called Magic Notes. That's been rolled out to 10 of our 11 adult services teams, involving 172 practitioners, so that's social work teams. And really that's about making sure that our social workers have the time to do social work, not admin. That's essentially it in a nutshell. So this is automating the admin step, and to make sure that practitioners really are focusing on the bit that we really want them to focus on, with having those meaningful conversations. And as part of that Magic Notes development, we've also brought in the development of templates and training, and the staff have been instrumental in developing that. It's been a real success story. And then last but not least, we've also had the Adult Services Workforce Strategy launched in 2025. So we've got 4 strands. So that's our internal task and finish groups, where the priorities are actually developed and delivered by the staff themselves. And we've got 4 pillars in the workforce strategy. We're looking at growing our own workforce. We're looking at staff development, well-being, and then recruitment and retention, or promoting adult services. So overall, an awful lot to talk about. But yes, that's the summary of where we are. So in terms of overall impact, there's a lot of activity. We're starting to see the right signs and a lot of really good performance information, or our measures of success that we know indicate whether or not this is working and whether or not we're aligning to our target operating model. It's coming through quite clearly. And it's essential that we continue on the same footing going into the next year to really continue to manage that demand and manage our resource pressures. So yeah, we'll continue to progress going forward into the next year. We have service planning coming up in the year, where we'll be reviewing what's been done, where we can improve further, what needs to be different, what can be new, and our governance of the project, just to offer assurance as well to panel, is managed locally through our Adult Services Continuous Improvement Group. And then we have our directorate reporting structures, and then lastly through cabinet reporting and the transformation board as well. So that's the end of the report, Chair. Thank you.
Thank you, Lucy. Are there any questions for Lucy again? Alan?
Yeah, not a question really, but I was quite interested to learn about the, what was it, the 21st or the 22nd century kitchen, and whatever. It'll be something I wouldn't mind having a look at if there's an opportunity, we could see that, because it's something I'd really like to see. But as a question, a simple one for me, and excuse my naivety here, I suppose, is on a purely practical basis, should I come across, when I have done on the odd occasion, somebody who is in need of support, I've often passed that on. I suppose it's called passing the buck. I suppose passing that on to the local area coordinator. But what are the steps involved for me if I need to refer that person on? I just wonder where I am with that.
Yeah,
Thank you.
I'll respond to that if that's okay. So as you mentioned, local area coordinators, or area coordinators as we're now referring to the team, because they cover larger sort of cluster areas. So we've got good coverage, are a part of our early help team. And our early help team, how you contact them is via the common access point. So the common access point, email, phone number, yeah, we can obviously share it with the colleagues afterwards, but it's available on our website as well. And that's just, and you come through to that team, you'll be supported with information, advice, assistance, as we've talked about, or it could be for a short-term intervention of early help via the community wellbeing team, area coordinators, some of our early help lead workers. So as Lucy said about Sue's been here before talking to you about the investment we're doing in this area. So we're putting a lot of investment in that space of more teams. So once you had the network of coordinators before, you've now, or very soon when everyone starts, going to have a larger team of early help lead workers as well. So yeah, anybody in the community you feel might need our care and support. What we would ask is that you get their consent, you know, if you want to refer on, you know, but certainly our team will always follow up. Thanks.
Sir? Jeff. Yeah. Councillor Jeff, Joe.
Yeah, thank you, Chair. Yeah, you mentioned, you know, we're certainly moving ahead quickly with technology and changes, and you know, training the staff and so on. You mentioned about, or it was mentioned earlier with regards to going out to tender and, you know, commissioning reviews and so on. How are we actually working with our perhaps external partners or other partners, you know, i.e. hospitals and so on, with regards to the changes that we are actually making? Do we actually update them, or do we tell, you know, changes in expectation from them?
Thank you. Yes, we absolutely do. So we as you're aware, we work very closely with our colleagues under the West Glamorgan Regional Programme. So all of our areas of focus are replicated across the region. Neath Port Talbot and the Health Board have a similar focus, of course. We're aligning in that way. And therefore, a number of the work streams that sit under the West Glamorgan programme of delivery echo what we're doing in adult services in Swansea. That's our main form of communication. So we have a prevention arm within the West Glamorgan Regional Programme, which we represent at, and actually can, you know, alongside colleagues in adult services in Swansea and across the region, where we provide updates and actually explore other opportunities and newer ways of doing things, and opportunities for joint working if we're working on the same things. I mean, one of my colleagues in Neath Port Talbot, who manages their assistive technology arm, we've done a lot of shared learning around our work that we've done with the assistive technology and digital offer. And we've done a lot of working with them. We're investigating further about an offer of a alternative means of like falls prevention, which links again with our assistive tech and our enabling people to live safely at home. And that, of course, touches then on our health colleagues as well, an ambulance service. So that cross-working is always at the forefront of our minds. And we do have, because of the West Glamorgan programme, a lot of opportunities to actually explore and really work together, which has been fantastic. The key bit, of course, I shouldn't ignore is as you say, about the hospitals and the pathway of care delays and the particular focus on that. There is a lot of work going on in that space, as you know, and as well as us having our own Swansea specific work, Lucy Holt in the transformation team in adult services works with our integrated colleagues, people that I think you would have met here, like our principal officer for integrated services, Andrea Preddy, Sharon Jackson, our integrated therapy lead, as well as numerous other colleagues across the region and health, all working together really to try to improve processes and systems, and again learning from each other as well. So but our main form of communicating and making sure that we do keep each other informed is the West Glam programme. I think that would be fair to say, Amy.
Okay, thank you.
Okay, Jack. Any other questions? I had the opportunity to go to the university who work closely with the health authority on virtual reality rooms, and that was brilliant. I think you need to go down and see down there as well, and maybe get, I think the professor was Professor Sarah Davis. It was mind-blowing. Just that. Thank you so much for your presentation. Are there any other questions now then? Okay. Thank you so much. We'll go on to our work plan 2025-26. Are there any comments on that? Just tell you that the next meeting is on the 24th of March, where we will look at West Glamorgan Transformation Programme again, including progress and mental health strategies, an update on inspections for last year. But we've got a budget meeting in February. 16th of February. So thank you all for attending. Thank you.